Hey guys, welcome back to the Foam Frat podcast. So we're going to talk about burns because July 4th is coming up and everybody's going to be doing some really smart things with firecrackers, screaming memes, hooskadoodles, hooskadon'ts with or without the scooter stick. But before we get into that, our goal was to start doing video podcasts. So that way you could actually see a different layer of it and you could actually see the conversations and the guests that we bring on. But we all of a sudden realized that like not all the platforms allow us to host video. So like Spotify or some of the Google podcast apps will not allow us to host video. So if you don't have an iPhone, you're kind of hosed because you don't get to see the videos. And you guys are probably wondering why we haven't put out any podcasts over the last couple months. It's because they've been video podcasts. So what we're going to do is we're going to post the audio as the podcast. But if you want to watch the video, you can still do that. The video is going to be posted on our YouTube channel. And you can go to YouTube, just type in Foam Frat, and you'll see all the videos where you thought we were slacking off because we weren't uploading podcasts. They're all there. It's just a problem with the video hosting. So we're not going to go back. I don't know. Maybe we will go back and just post the audio of all of those. But from this point, we're going to release the audio and then we'll release the video on YouTube. So if you want to see our smiling faces, you have to go to YouTube. All right. Now, let's get on with the actual topic. So, Ben, why did I just call you Ben? Dude, I'm not even getting...
You've been talking to our developer too much, man.
Dude, I was talking to Ben all night last night. But Sam, I don't know. I'm not even going to cut that out. That was hilarious.
Yeah, just keep it.
So, Sam, why burns right now?
Yeah. So kind of the reason that you said the blog is going to be called For Those Who Play with Fire. And I figured I was thinking about doing it anyway, because there's always some follow-up questions to one of the classes that I do. So I guess we have them recorded too in the refresher, but I do a couple live classes and it's called Serial Arson. And I have this whole like noir mystery theme that I use for it. And the premise of the class is that we're following around a serial arsonist in our response area, and he's doing a bunch of wacky stuff. Like he's dumping dry chemicals on people, he's dumping wet chemicals on people, he's starting fires and stuff.
Sounds like a real jerk.
He's a real jerk, and we have to follow him around. And since all these calls are happening, the premise of the class is that we're trying to prepare ourselves for how we would respond to these different chemical burns and these different thermal burns and stuff like that. And then there's actually a cool follow-up to the 2-part class. And in the follow-up class, we do it's called Serial Arson, the Expert Witness. And what we do is we evaluate the cases, because in the first class they kind of make a decision as to what the care would be. And then in the second class we come back and we say, okay, now we're on the stand and this guy's being tried. Like he was caught, and we have to be the expert witness on the burns and evaluate what the crews actually did. And so we look at some of like the possible pitfalls and stuff. And so I've been wanting to talk about this because there's a few things in the class that people were like, I can't believe that's real. Like that's really messed up. Like that's the way that you do things, and this is usual care. And so I feel like there's a lot of misconceptions about burn care, especially in the pre-hospital and even like early emergency department treatment. And so I was thinking, if there was a time to release this, it would probably be topical to release this right ahead of the July 4th weekend. So hopefully we'll release this on the 2nd or 3rd. I think on the 2nd we'll probably release this.
Yeah. So the first thing that we wanted to dive into was the total burn surface area. And this is an area that I'm notoriously, self-admittedly awful at. And I can remember one of my first burns. I told the hospital that they had 90% burn surface area. And I got a feedback later from the one of the follow-up nurses that said that the actual burn percentage was like 15. So like I said 90 and it was actually 15. I just, I saw soot, I saw it, maybe some blistering, and I just eyeballed it because I wasn't really sure. I don't remember the rule of nines. I forgot that after I took my national registry. I remembered
Mhm.
the palm rule, but I always was confused. Is it my palm? Is it their palm? Does it include the fingers? Is it the back of the hand? So give me some clarity. How can I better estimate the burn surface area?
Yeah. So first of all, having a reference for the rule of nines, because that is like the best gross estimation. There's another rule that the actual burn center will use in the ICU. I can't remember what the name of it right now, but it's very exact. But for us, rule of nines is best. And so if you just have a reference in your protocol or like a cheat sheet that you can pull out, or you have a picture and just Google it, obviously it'll come up right away. So that's the best way to estimate those burn surface areas. But honestly, it's the only thing that you're trying to figure out is, does this patient have to go to a burn center or not? And so your friend that you work with, Erik Rima, left a peer review in
Used to
here.
work with.
Oh yeah, and so he
Still
used to
salty
be
about that.
yeah, so he used to be a burn center ICU nurse, and so I asked him to come in, review my stuff, make sure I'm not completely crazy with what I was saying and stuff. And he was saying that the first thing to realize is that EMS's role is really to just figure out big burn versus little burn. And if it's a big burn, it seems really serious. And there's a few criteria if you look it up for burn centers, like if anything involves high voltage, if it involves their face, if you think it's inhalation, if anything is circumferential, like there's several things that, regardless of the total body surface area, that you'd be like, okay, this is kind of a messed up circumstance. Like these ones are going to get triaged right to the burn center. And so that's kind of the first thing. Is like there's kind of some criteria that okay, you're like, okay, automatic, this is burn center criteria. But the total body surface area, the more I looked into that, the more you realize that the initial assessment of these things, and so you shouldn't feel too bad about your 90 versus 15% thing, is horrible because, like you said, they're covered in soot. They've got like melted clothes stuck to them. They're dirty. They're moving around. We have poor lighting conditions. And so to think that we're going to get an accurate body surface area burned is ridiculous. We just probably, I don't want to say we shouldn't try. Like, you want to estimate, look at the rule of nines, look at what you think is burned. And by the way, the only thing that gets put into that total body surface area is anything blistering and worse. So first degrees, or what they call superficial burns now, that doesn't count. So if it's blistering, whether that's clear blisters or red blisters, or if it looks like a third degree, so it's white, ashen, charred, insensate, like stuff like that, that stuff gets counted. Your first degrees don't. And so that can be confusing on its own, because it's like, where does this blistering area kind of stop? Where does the first degree burn? And so it's very, very difficult. And so if you apply that, and we'll get into it in a second here, but if you apply that to a burn formula, you're assuming two things. The first thing is that you actually have an accurate total body surface area, which we don't. Nobody will until they get to the ICU and they clean this person up. So first of all, automatic, that's inaccurate. Second thing is, and we're really good at estimating kilograms. So like, the two things, and you're just taking, it's essentially a total guess when it comes to estimating this total body surface area and their like, I guess we'll get into fluids next, but total body surface area and their kilograms. And by the way, you mentioned that thing about the palm. So I always ask that in the class, because we do go over a thermal burn case. And I always ask them, I put my hand up to the screen. I'm like, do you guys think it's this? Like only the palm, the patient's palm. It's always the patient's palm relative to their size. So first of all, it's the patient. Do you think it's the patient's palm like this, like only without the fingers? Do you think it's like this with all the fingers out, where it's almost like you're trying to palm a basketball? Or do you think it's like this, where you are, where you have all the fingers together and it's always, their hand? And the answer is, it's the palm plus the fingers together, as if you were, on your tippy toes trying to, reach the ceiling. So that's confusing all on its own. And if you wanted to get really confused, just type that in Google and type in like rule of palms, and you'll see a bunch of inaccurate stuff. But if you actually go to advanced burn life support, they have a graph in there that shows the patient's hand with fingers together, and that's all included. So it's an
Including the
approximation,
thumb?
including the thumb tucked against the hand.
Because these are fingers. This is
Let's not get into it, but this is
you
correct.
remember that when you were a kid, you'd be like, how many fingers do you have? And it'd be 10. And be like, nope, these are thumbs. So it is including the thumbs.
It is including the thumbs, so don't forget the thumbs. It's if you wanted to get really specific, that is an approximation. So if you wanted to get a real stickler about it, their hand is probably 0.8%, including the thumb, with the fingers. But Advanced Burn Life Support says that this is an approximation when you're doing rule of nines, and so just round it up to 1% because it's gonna be inaccurate anyway. So you're just really trying to differentiate between big burn or little burn. Like, does this patient have burn center criteria? And then just ballpark it, and it's probably a little bit less than you think. And so, but it's not an exact science. So that always used to give me some anxiety. Like, will I realistically be able to estimate this? And what if I get there and I'm wrong? And there's all of this, am I going to look stupid type stuff? And you shouldn't worry about that. Anybody who understands initial burn care is going to understand that this is not an exact science. It's a messy, messy thing when you're talking about, the burn depth and the area and all that kind of stuff.
So big burn versus little burn. Burns to areas that are more concerning, like the face, cosmetics. Burns with high voltage, like electric burns. Those should all trigger us that we want to go to a burn center. And then if you're going to do something like the palm rule, you're using your thumbs and fingers, and that's the patient's palm. It's their whole hand, right? It's just their entire hand. And then the most accurate thing probably is the rule of nines, but you're going to need a reference because if all you remember is that the genitals are 1%, then I think we're on the same page.
Yeah. So, and the other thing too is if you have difficulty getting a measurement of the patient's hand, I mean, you can put your hand up to theirs, I suppose, and then ballpark it from there. But the other thing that you can do is just tear off an empty, a blank run report or something like that, put it up to their hand and just rip it around their hand until it's about the same size. And you can place that up against the patient and say, okay, 1%, just something quick. You don't have to, if you have trouble, like, comparing your hand.
I'm imagining like using their actual hand while they're in pain. And you're
oh, geez.
Yeah, bring some construction paper and just draw it and cut it out, and then you can just use that.
Yeah. So that's where everything starts. You're starting to assess this patient, and you're like, how bad are they burned? And you're starting to look at blistering. Is it a full thickness burn? And then do they have this burn center criteria, which is tough to remember. So this is the kind of stuff that hopefully you have a page in your protocols or something like that shows you if they meet this criteria, go to a burn center automatically. And then, maybe a big picture of the rule of nines or something that will quickly show you, just estimate it and ballpark it. That's kind of the beginning steps.
Cool. All right. Well, the reason that we need to know that is because we need to calculate a very precise formula for how much volume to give. So once we have that total body surface area that's burned, and now we need to apply either the Brook or the Parkland formula or the consensus, which is just both of them, and then you pick one. And so, how do you remember how to calculate that? Do you carry do you have like a calculator watch, or what are you doing?
Yeah, my Apple Watch has a specific burn formula. No, not at all. So yeah, Tyler's baiting me right now because in the blog, one of the first things that we start off with is, do you even need a burn formula? And the answer is no, you don't need a burn formula. Because first of all, everything that we're calculating is inaccurate anyway. And so there's really no point in trying to get really exact with it. So in the blog, I use this example of a patient that's 80 kilograms. So just to kind of show how silly this is. So imagine that you have a patient that's 80 kilograms and they have 20% body surface area burned, right? Yeah, we'll start with that. So if you go through that whole formula, which I'm not going to do right now, but it ends up being 200 for 20% burns, 80 kilogram patient. It ends up being 200 milliliters an hour. And if you double that, so let's say you have a patient that's 80 kilograms, 40% body surface area burned, it ends up being 400 milliliters an hour. So if you think about that, like, we always associate the burns with need to give, like, oh man, what if I can't get IV access right away? Like, this patient needs to have this fluid like right now. And imagine you're with this patient for a half an hour, right? How much, and they have these 20% body surface area burns. If it's 200 milliliters in an hour, what is it in a half an hour? It's 100 bag. So I bring out in the blog that, like, by the time you start an IV, flush it through, make sure it's patent, give a few medications, flush them, and you have this maybe at a keep open rate on the fluids without even giving a bolus, you are probably almost right where you need to be without even giving them anything. And then the same thing is true for, let's say you're with a 40% burn patient, 80 kilograms, you're with them for a half an hour. That's 200 milliliters. You're not even giving a whole 250 bag in probably the entire time that you're with that patient. So it's kind of silly to think that we would need to administer that. The caveat is obviously if this patient is hypovolemic or has a trauma from another reason, right? So if this patient has, was in a very hot environment for a long time and they were sweating bullets and they're truly dehydrated, or if this is associated with a trauma and you need to give this patient blood, that's a whole different story. But if we're talking about strictly fluid loss from burns, it's not like this patient got burned and then boluses left their body, right? They don't lose fluid in boluses. They lose it at a very slow, steady rate as these things start to leak, right? So to think that we have to jump on and get ahead of fluids and all this kind of stuff is kind of silly unless you have a real reason to believe that they were hypovolemic for another reason. It's like hemorrhage or strict like dehydration or something like that.
It's funny because I remember in the National Registry extended scenario where they have a paramedic student go through and they have to spend a lot of time with the patient. One of our buddies went through it, and I was actually the examiner, and he had a patient with a burn to the hand, and watching him try to calculate that formula was one of the funniest things I've ever seen in my life.
Just to the hand?
What? Yeah,
Just to the hand?
It was just the hand. And so he's trying to calculate how much he's going to do. And, you can imagine, he's got, just imagine 1% burns and he's trying to calculate a burn formula for it. And I was sitting there thinking, like, this is the most ridiculous thing I've ever seen in my life. I mean, it was like 1 ml every 10 minutes or something like that. But it's ridiculous.
Incredibly low. It would be super low.
Like, I don't think the problem with Parkland is that we're over resuscitating patients with volume. That doesn't seem like that's because it just, I think it would be really hard to do that, but it's really just a cognitive offload. Like, don't worry about that. And I like what Erik said in his peer review. It's more about just keeping a steady flow of fluids going as opposed to giving a bunch of boluses, right? Because you're wanting to wash out any of like the myoglobin or anything that could cause rhabdo. You don't want the kidneys getting clogged up with anything, and you're losing fluid in probably a slow shift. And so that's probably how you should give it back instead of just doing these rapid boluses. So the recommendation now is to just do 500 mLs an hour. Right. And I think that's important that it's not a blanket 500 mLs, because that can be a little bit confusing we should just give 500 mLs. It's 500 mLs an hour. Right.
Yeah. Yeah. And then there's pediatric dosing in there too. And I don't want to say the ages or actually, hang on. I'll just tell you, I have the blog pulled up somewhere. So I wrote it down in the blog. So advanced burn life support will tell you that it is. Here we go.
Can you hear my chair when I do that?
No, but I have my volume turned down so you don't come through that thing. But 5 years old and younger, 125 an hour. 6 to 13 years old, 250, and then 14 and older, they get 500 an hour. And that's always lactated ringers is what's recommended for those patients. So yeah, really young, you're looking at really small fluid, like 125 an hour. Graduate up to 250 when you're between 6 and 13. and then you turn 14, and then you're looking at 500 an hour. So that's so simple. Like that takes so much stress, and I'm like I'm picturing somebody sitting there. They got a patient who's in like horrible pain. They're freezing cold. The burns haven't been dressed, and somebody has been it's been drilled into their head that this burn formula is like the cornerstone of treatment. And then they get the amount of fluid, and it's like 100 milliliters an hour. So like and like if you think about how slow that rate is, it's ridiculous. And you just keep that tiny amount of fluid going while you're on your way to the emergency department or during
Meanwhile,
I guess
meanwhile, the paramedics have a run report up to their hand, and they're cutting out like it's arts and crafts time.
Origami or whatever you call it. They got this little thing to do. Yeah. So there's certainly things that are very important in burn care, and fluids are one of them. It's probably just not in the manner and and just not as expedited as we have probably been made to believe it is. Because I mean, that's probably the first thing you think of. You think burns, and then what's the first thing that pops into a paramedic's head? Burn formula, Parkland burn formula, which nobody uses Parkland anymore. Nobody uses Consensus. Well, I guess technically
they do. There's still a lot of people that do. Like,
yeah,
I think in our circles, a lot of people aren't, but it is still commonly taught. And I want to say it's still on the National Registry. I remember walking in to take the National Registry and drawing out a little person with the rule of nines and the Parkland formula because of that.
Yeah. So the Advanced Burn Life Support Manual, which I did link in the blog, it's free. There's like a 2000. I think they actually did some updates in 2019 too, but it's a 2018 provider manual. It's free online. You can just look at the PDF, and you can just search the page and look at some of the stuff. And that Parkland formula is commonly associated with over resuscitation. And then they get edematous. That's not good for the burns, and they get acidic. All this kind of stuff. Like a bunch of badness ensues. So yeah, something to look at. So the Brook formula, that's what I was using for those examples. And I was telling you about the 20% and the 40%. That's the Brook formula, which is 2 mLs per kg times the body surface area. But it doesn't even matter, because unless you're taking a transfer where they've already set this up and you're just going to be continuing the rate, pre-hospital, we're not even going to be worried about that. I mean, follow your local policies and procedures, whatever. But the standard practice now is focus on the important stuff and just use these default rates, because it's going to cover most people. It's probably not going to over resuscitate them because it's not enough fluid. But it's, even if you have really bad burns, maybe it under resuscitates them just a little bit, but it's going to be easier for them to catch up later. They would probably have a patient who's got a tiny bit behind on fluid than a patient who is massively fluid overloaded.
And I think in my head, like if you actually calculate the formula out correctly with the total burn surface area, it's probably not going to over resuscitate them. But the problem is we are notorious at overestimating the amount of burns. And then when you add that formula on top of that, it seems like that's where you start to get into some issues. All right. So
yeah,
that's
you get
easy.
that. Oh, I was going to add, like, we probably overestimate the amount of burns. And then the other thing that we do is we always give fluid too fast. You think that it's going to take forever for that amount of fluid to go in, and then before you know it, it's gone. Like, in a pre-hospital scenario, can you picture giving 500 mLs an hour? Like, what does that rate even look like? Like, unless you're putting it on a pump, you're probably going to give it too fast. And so, yeah, just adjusting our brains just a little bit to go maybe more conservative on both those sides.
You look up and the bag's empty, and you're like, oh,
that happens. Yeah, exactly.
It happens all the time. You don't even realize that it's happening. All right, so let's move on to pain management, and this is interesting. This is always a fun topic to discuss, because it seems like it's somewhat institutional specific. So it depends on your program or your shop, what they're using. But I was taught that ketamine was kind of the magic bullet when it came to burns, and that was a situation where ketamine really had a lot of feathers in its cap as far as its efficacy. Is that what you were taught as well?
Yeah, and I don't want to totally discount that, but I don't think, there's a few reasons that it's not the cornerstone.
Yeah, so in your blog, you talked about how the majority of your experience was interfacility transports, where they'd already been loaded up on opioids, and now you came and you added ketamine, and it seemed to do the trick. And so in your head, you're sitting there thinking, oh, ketamine works better. But it's
Yeah.
probably because it's not monotherapy. You were doing two different things, and maybe even adding a benzo in. I saw Rima mention that they use midazolam occasionally during debridement. So I thought that was interesting. And I think that holds true to what I've seen, is that when I go to a burn center, the first thing they're doing is they're reaching for the fentanyl and the midazolam. And I'm like, well, I got a ketamine drip running. And like, okay, that's cool. We mostly use fentanyl, but it probably does depend on the place.
Yeah, for sure. So it is very institution specific. And with the ketamine, with those patients that I would frequently see, I mean, if it's an interfacility transport, they're going to be giving them fentanyl right away, something fast acting. And then a lot of times they would also receive longer acting. And so they would receive some Dilaudid, some hydromorphone. And so that stuff is like, and they're saturated, and I don't know if you've had this experience, and, one person's experience is worth exactly one person's experience, but sometimes I would see patients and it's like they would be still uncomfortable, but they would be kind of toeing the line between respiratory depression. And so they could kind of fall asleep. They'd get a little bit of respiratory depression. You'd have a nasal cannula on them and title just to watch their respiratory rate and stuff. And then they would receive a little bit of stimulation, like moving them or a big bump in the ambulance or something like that. And they would freak out and they would wake up, and it would take them a little bit of time to kind of get back into that sedated state. And so and I'm sure other people have had different experiences with that, but I was never quite happy with just the opioid. And so I always felt like and like I said, this is my personal opinion. And so when I would give them like a small pain dose of ketamine, it would get them, it wouldn't further depress the respiratory state, and they wouldn't have as many highs and lows. Not to say that they wouldn't have any, but they wouldn't have as many highs and lows if I gave them this very small pain dose ketamine. And by that, I mean sometimes flat 10 milligrams, 20 milligrams, or maybe weight basing it where you're given maybe 0.2 or 0.25 milligrams per kilogram, very slow. And you don't have to give even the whole thing. You can give a little bit and just see how they respond to it, because you're not putting them into that partial dissociation range where they're going to freak. You're staying very low on that ketamine ladder. And so I feel it's safe to give those very small aliquots of ketamine. And I just in my personal experience, it kind of got them through those highs and lows a little bit better. But I do think my caution, and I was thinking about this a little bit more after we talked about it, another feather in the cap of ketamine would also be, there's a couple. One is you can give it IM in the initial burn patient. If you can't get IV access right away and they're freaking out, you could do that. So that's one other possible use case. The other is that if you use a ton of benzos and opioids, you can make them hypotensive, then you need to give them fluid, which you don't want to fluid overload them. So there's a careful line there. But one bad thing about ketamine that I didn't previously think about when we were talking about this is if you use that, especially as initial or sole therapy, I was thinking, depending on the dose, they might have a bad trip because they're freaking out and they're in a ton of pain and they're scared. And we always, before we give somebody ketamine, we usually try to get them in a good place. But I don't think that these patients are going to be in a good place. And so that could set them up for some potential like psychological trauma from it, which wasn't something I had previously thought about. So that's where I think the opioids and maybe a little bit of like benzodiazepine or something, some type of GABA agonist is probably good for initial therapy, unless you really have to like there's going to be extreme cases where you just want to disassociate somebody maybe now. But I think that getting them to chill out before ketamine is probably better. What do you think about that?
Yeah. So it's interesting. So I typically hear people refer to wanting to aim for dissociation with ketamine when they're talking about pain. And I think that that's the complete wrong way of looking at it. You don't want to have any real neurological, I don't say neurological because I guess you could say pain relief is neurological, but you don't want to have any mental status, central nervous system changes where they're tripping out. If you're doing that, then you're probably giving it too fast or you're giving too much. And so I really like, excuse me, I really like Dr. Antevi's guideline. I want to say it's like Coral Springs Fire, but what they do is they take 50 milligrams and they put it in a 50 ml bag and they run just 25 of that in, and they just let it slowly run in, just a nice slow rate. And then if the patient's pain goes away at that point, then they stop it. If not, then they'll run in the other 25. But it's over a long period of time. They're not like just rapidly pushing it. And I think that makes a lot of sense. And I actually had him on the podcast a long time ago, and we talked about that. But some of the situations I've been in, I've had patients who are in extreme pain who are begging you to please just put me out, put me out. And it's very hard in those situations to want to stave off intubation, even if, I don't even want to get on the topic of intubation of burns, but I wonder, do you think it ever makes sense to intubate somebody just because the amount of pain medication and benzos and stuff that they're going to require would compromise their breathing and compromise their respiratory status? What's your thoughts on that?
I think it depends on the conversation that you have with a patient. So I mentioned this in the blog too. If the patient, because maybe your goal can't be zero pain. I don't think that you're going to get to a place where, and especially because we're talking about severe burn patients here who are in a lot of pain. This isn't the person who burned their hand and we're just trying to make them comfortable, right? So we're talking about severe burn patients here. So if they're able to communicate with you, even what's an acceptable pain level? And this is probably a conversation that takes place after a little bit of initial pain management. Maybe they're still uncomfortable, but they can actually have a conversation with you. And maybe that's the point to say, like, what is an acceptable pain level to you? Because if we go any further than this, like, I'm afraid we might have to put a breathing tube in you, and that's a procedure where you're going to be totally out. And so I don't know, I feel like there's a little bit, and you can what if that situation to death. Right. I feel like there might be a place for a conversation with the patient on what is an acceptable pain level, and kind of like a slight warning about the medications as well. Because you're not going to get them to a comfortable zero where they have absolutely no pain and they feel great. If this is a severe burn, like, their nervous system is going nuts, and so you can blunt it, but are you going to completely get rid of it and have this, oh yeah, thank God for that medication, like, I'm totally fine? I don't think so. So if you can't control it, like, absolutely, and they're freaking out, there is some guidelines out there, like from Advanced Burn Life Support, where if it's 40, 50% and some other criteria, we'll do a follow-up podcast on airway burns because that is a topic of its own. But there are some criteria where that would pretty much trigger you to where that patient should probably just be put into a medically induced coma for pain control.
Awesome, man. All right. Well, great post. Thanks for hanging out and listening to us chat. And if you're interested in more conversations like this, check out the Foam Frat EMS library. It's a library of close to 200 hours, live classes, Monday through Friday, 3 days a week, twice on Friday. Head down to the bottom of this blog post and you'll see a link. Click on it. We'd love to have you in the class. All right, buddy. See you next time.